this lunchtime. As you may have just heard, this webinar is being recorded, just to let you know, so that we can make it available to people after the session who may find it useful. So my name's Alice Webb. I am a Maternity Action trustee and I'll be chairing this webinar. We're going through until 1:30 with a series of speakers and a Q&A at the end for about 15 minutes. And on the Q&A, please can you submit any questions as we go along through the speakers via the Q&A function, please, rather than the chat. And as I said, you can do that as we go along, and then we'll see how many we can tackle at the end. Just a bit more of an introduction. Today we will be launching our new updated access guide, a guide which has been jointly produced by Maternity Action, the Royal College of Midwives, and the Royal College of Obstetricians and Gynecologists. This guide's been produced to help NHS Trusts improve practice around NHS charging at trust level. And the guide will be introduced by Ros Bragg, Director of Maternity Action. Then we will also hear from Dr. Brenda Kelly. Brenda is a consultant obstetrician and clinical lead of Oxford Rose Clinic, part of Oxford University Hospitals NHS Foundation Trust. And she will discuss some of the policy and practice developments at Oxford NHS Trust. We're also very pleased to be joined by Megan. Megan is a member of the group United Impact, and she'll be representing people who have experienced NHS charging. United Impact, supported by Project 17, is a group of around 60 people with personal experience of no recourse to public funds. And we will also show our new Rosa Fund Voices from the Frontline video, where we interview Catherine Letley, a midwife lecturer at the University of East Anglia, who discusses some of the issues around charging migrant women for their care. These videos have been funded through the Rosa and Voices from the Frontline Fund, and we'd like to thank Rosa for the support and guidance. So thank you very much, everyone, for joining us. Thank you to our speakers for joining us, and it's now over to Ros to introduce the new guide. Over to you.
Thanks very much, Alice. We're delighted to be launching the guidance on improving access to maternity care for women affected by charging, which we're calling the Access Guide for short. As Alice said, this is work that Maternity Action has jointly undertaken with the RCM and with RCOG. What I'll do is provide some brief background on Maternity Action for those of you who haven't come across us before. Then I'll take you through the aims of the Access Guide, what it contains and how to use it. So firstly, Maternity Action is a national charity campaigning to protect and strengthen maternity rights and employment, social security, and the rights of migrant and asylum-seeking mothers. We're celebrating our 15th birthday this year, and the charity directly advises just over 3,000 pregnant women and parents each year. In addition to our advice services, we engage in research, policy and campaigning in the areas in which we provide advice. Maternity Action has a specialist advice service for women affected by charging for NHS maternity care. The advice is both for those who have been charged and those who are at risk of charging. It's a service which is available to women and their partners, friends and family, and to clinicians and voluntary organisations. It delivers free expert telephone and email advice on NHS charging, and it offers legal representation or casework support for women who do need that additional support. It's a service which is headed up by an experienced public lawyer, Christine Benson, and as I said, it's a legal advice service. It was awarded the Halsbury Award for Rule of Law in 2022, which recognises a sustained contribution to promoting the rule of law. So through this service, each year we deliver advice to 500 women, and we provide casework support to around 80 women. Our priorities for casework are women who are undocumented, who are destitute, survivors of domestic and sexual violence, survivors of trafficking, asylum seekers, refugees and EEA nationals. Of the women we took on for casework last year, all were from Black and minority ethnic backgrounds, and over 80% had incomes of less than £10,000 per year. So this is a very vulnerable group of women. Through this service, we receive very good data on the experiences of women affected by charging, and this has underpinned the development of the Access Guide. Our work is also informed by our research projects. We've undertaken a number of research projects exploring the impacts of maternity charging. They've looked at women's experiences, the experiences of clinicians, and they've also analysed data from our advice services on practice within trusts. These reports are all available on our website, and I encourage people to have a look at those. So now to the Access Guide. What does the Access Guide aim to do? We're aiming to assist NHS Trusts to minimise the negative impact of charging on migrant women's access to maternity care. This is a group of women at very high risk of poor maternal health outcomes, and access to maternity care is of critical importance in reducing the worryingly high rates of maternal mortality and morbidity amongst this group. And some of our later speakers will say more on the health inequalities issue. The guide is targeted at NHS Trusts, calling for a change in administration of charging. This involves the Overseas Visitor Team and the Finance Department, as well as maternity services. The practices of overseas teams and finance teams are as much a part of NHS service delivery as maternity services themselves, and directly impact on women's access to care. As I said, the guide is targeted at NHS Trusts. It is not a guide for clinicians who are supporting women affected by charging. We will be releasing documents which do this, but this is an entirely separate piece of work. The guide is targeted at NHS Trusts in England. There are different regulations in each of the 4 nations, and the guide is based on regulations in England. It may well be useful for those working in Scotland, Wales and Northern Ireland, but it doesn't necessarily reflect the law in those countries. The Access Guide is in 3 parts. Part A is our guidance for trusts, outlining the changes in policy and practice which are needed to reduce barriers to access. Part B outlines the evidence showing that charging is a barrier to accessing maternity care and the implications of this for maternal health inequalities. And thirdly, in Part C, we list the relevant law and policy which supports this guidance. The guidance covers different stages in women's interaction with maternity services where charging is an issue. In fact, the different stages in women's interaction with the NHS. It covers the information provided by the trust, maternity appointments, advocating for women affected by charging, resolving chargeable status, invoicing, dealing with debts, communication with the Home Office, and audit processes. And our recommendations on audit are both about what happens in maternity services at a clinical level and what happens in the finance departments, particularly the overseas visitor teams. I won't take you through the detail of the guidance given the limited time this morning. What I would emphasise is that the Access Guide works within the existing legal framework. We know that trusts are bound by the charging regulations, and these require them to charge certain groups of people. The guide works within these legal boundaries, and we're entirely transparent about this with that 3rd section of the guide documenting the law and policy which underpins the recommendations. So this law and policy includes the charging regulations, but also the wider legal framework which governs the work of NHS Trusts in England in this area. So how did we develop the Access Guide? We reviewed the evidence from our advice service. We reviewed the academic evidence. We reviewed Maternity Action's research reports. reviewed the relevant law, policy and guidance relevant to maternity services in England, and the law, policy and guidance relevant to the financial aspects of charging in England. We worked with the RCM and with ARCOG to ensure it reflected their concerns, and they tested it with clinicians. What we would like NHS Trusts to do with the guide is to adopt it and to commit to implementing it. As I said earlier, it is not a guide for clinicians, it is a guide for the Trust as a whole. Implementing it will require changes within finance departments and overseas visitor teams, as well as within clinical services. The guide is intended to be a complete resource. It contains specific recommendations for change, the evidence base, which demonstrates the need to reduce barriers to care, and a detailed note of the relevant law and policy which underpins it. However, we're also producing additional material to support trusts to implement the guide. We're producing a series of short videos sharing women's stories. We will also have videos from clinicians and advisors. Some are available now and others will be released in the next few months. We'll also be sharing examples of good practice within trusts, and we're delighted to be able to do this. We hope that these resources will help deliver change within trusts. I mentioned at the beginning of my presentation that Maternity Action undertakes campaigning work. We are active in pushing for changes in charging policy and the legal framework, and further information on this is available on our website. The Access Guide does not form part of this work. The guide does not ask trusts to act contrary to the law or to government policy. The guide is focused on improving policy and practice within NHS Trusts in England and working within the law as it currently stands. Maternity Action, RCM and ARCOG have taken care to produce a guide which we think will effectively support trusts to make the changes needed to better support women affected by charging. As always, we're open to comments and feedback on the guide and look forward to hearing from you all. Thank you.
Thanks very much, Roz. I think we are now going over to Megan, who is speaking representing members of United Impact, who are a group who represent people who have experience of being charged for maternity care. So if you're here, Megan, it's over to you.
Okay, I'm here. Good afternoon, everyone. Thank you for the introduction, and it's my pleasure to speak on behalf of United Impact. Like you rightly said, United Impact has a lot of people with lived experience, or we are actually all members. All the members are people who have lived experience of no recourse to public fund, and most of us have experienced maternity charging, which is the reason why we have to come to speak about it. The impact, today I'll be focusing on the impact maternity charging has on the members or on those who have experienced maternity charging. Some of our members reported that after giving birth, they had some complications, especially one member who had a complication that left her in the hospital for almost a month for her and her newborn. And after a month, she was discharged. And that followed with a bill of £23,000. This particular member was having difficulties in her relationship. She had a broken down relationship. She had received her recourse to public fund, but she wasn't working yet. She had some health issues, and then she was left with this bill of £23,000. As if that was not enough, she was due to renew her 2.5 years, as she was in 10 years rules. And when she approached her lawyer to make the renewal, the first thing the lawyer
Megan, I think you've dropped out a bit. Can you hear me?
Is it any better?
Yeah, we can hear you again.
Oh,
Carry on.
sorry about that. It's network. I don't know where you stopped hearing me, but I'm talking about a member who was given bill of over £23,000.
Yeah,
And she was supposed to do renewal for her status. And her lawyer asked her, and she said she had a standing, which became a serious issue. The lawyer told her that if she doesn't sort out her standing, her application might be rejected. This made her go into depression because she didn't know where to start from. She didn't have anyone to help her. Her relationship had broken down. She didn't have a job. She had a child before having the second one, and both were young. She was confused, so she had to set up direct debits to try to pay the outstanding from the little money she's getting from benefits, which was the only source of income she had. And this was happening in this recent time with high cost of living. So that left her almost hungry for her and her kids. She was not able to afford nappies for her kids. She was not able to afford basic needs for her kids. She was so broken and depressed to the point that she could not produce breast milk anymore. Her doctors had to place her on antidepressants as in hope that her situation could get better. And then she had to apply for her status. Another member also had another experience with maternity charging. This member had diabetes, pregnancy diabetes. And because of that, she had complications. The baby had to be taken out before the due date. And after the operation, she was given a bill of over £13,000. The situation didn't get better. The diabetes got worse as time went on. So she had to frequent the hospital. And one of these times, there was an emergency at like around 2 a.m. She went in and they had to call social services to take her child so that she can be adequately cared for. After the care for about a few days, she was discharged and given another bill of £7,000 plus the 13,000 she had. And then she was referred to go to a specialist to handle the situation. When she got home, she got a follow-up letter from NHS saying, you have to pay up their standing or don't bother attending the clinic we referred you to. And this was followed up with another call and so on. This lady was scared to the point that even though what happened few weeks after was not connected to her, there was a police van parked near her where she lived. She thought they were coming for her because she didn't have her status. She was undocumented at the moment. She was fleeing domestic abuse and so on. So she felt that NHS had all that information and they were coming for her, or they had sent immigration to come after her. She was so scared and became so depressed and confused. For 4 days, she didn't go out of her apartment. She was hungry at home. She was confused. She didn't know who to talk to because of the fear. She became depressed, couldn't feed her child. She couldn't get proper medication for her situation. Luckily enough, I was living close to her at that time, and I hadn't seen her for over 4 days, so I had to knock on her door. I was concerned for her, and she told me she was trembling. And she told me that she's so scared. She got a call from NHS that she has to pay her outstanding, else she shouldn't bother going for the the referrer. And her situation was bad. The insulin they gave her, they prescribed, had finished. She didn't have any money. She didn't have recourse to public funds. She only had the little subsistence provided by social services. So I said, well, do you know Maternity Action? She said no. So I quickly told her about Maternity Action, gave her the contact. And she said she's so scared she can't even call anyone because she felt the bus that was around a few days ago with police, the police van was for her. I said, don't be scared. You haven't killed anyone. Even though you're undocumented, it doesn't mean, you have committed any crime. You are in court trying to sort out your matter with your daddy, your baby's daddy, and so on. So she called her support worker, who finally contacted Maternity Action. And luckily for her, they were able to sort out these bills, and she was debt-free at that point. But she still felt scared of going for her clinics, which made her situation to deteriorate. Because of this and many more that time would not permit me to talk about, we at United Impact think that maternity charging should be completely scrapped, because a lot of people are going through so much as a result, especially as a result of the constant calls, the messages, the letters they get. They are scared to even look after their own health as a result of what the threat they have received from from NHS charges and the people, the people working on their behalf. Many of these things are also affecting the children. Sometimes we focus on how the parents are affected, but can you imagine how the kids are affected? A kid that stopped breastfeeding at 3 months, what would that child's life be like? Another child was, detained with the mother on their way back from a funeral. The mother suffered bereavement while owing NHS charges. And on her way back, she was detained with her kids for questioning at the airport. Even though this has happened several years back, the kids keep asking his mom, why were we detained that day? Why were we different from others? Why were we not allowed to go? Why were we kept back for several hours? Why were they questioning you so much? And each time that happens, the mother breaks into tears. This thing does not go away from the children. So they are highly impacted, and they grow up feeling inferior, feeling let down, feeling that their parents didn't deserve a better place in the society, and so they too didn't deserve a better place. Because of this, even as I talk, it's with so much tears in my eyes, because if I have to talk about what people have gone through as a result of this maternity charging, time would not really permit it. We are pleading that things should be done properly. Thank you very much.
Thank you so much, Megan. Thank you for bringing home the impact of charging on women and children so powerfully. I'm now going to pass over to Dr. Brenda Kelly, who's going to be discussing her work at Oxford University NHS Trust on improving policy and practice on NHS charging. So over to you, Brenda.
Thanks very much. And I'm absolutely delighted to be here today to support the launch of this incredible framework. By way of background, I'm a consultant obstetrician here. I'm also clinical lead for maternity safety. So I have seen the adverse outcomes that can happen when women default from maternity care through fear of charging, or when they have been charged in subsequent pregnancy, in terms of how that's impacted forward into their pregnancy after that. I also work as clinical lead for maternity health and equalities. And I would say that rather than go into great detail about how we've managed this locally, I would just really give the broad brushstrokes. So what I really hope for this access guide is it will support organizational change at trust level. And I do think that any trust that is signed up and committed to reducing maternal health inequalities, which I sincerely hope every single trust in the NHS is, that they should be implementing this access guide without delay. I think one has to understand the pressures that overseas teams work within, and I'm certain when I first and my team here first started in conversations from maternity to our overseas team, it was interesting just to listen to that element of things, that they're under huge pressure to recover costs. But there is a misperception that those who they are approaching are somehow health tourists. So I think if we're going to learn from what we've done okay with in Oxford, and if we're going to implement this into trust, trust every day, when it comes to how overseas teams work within maternity, I think first and foremost, it needs collaboration. It needs joint working between maternity services and the overseas team. Many of the overseas team are working from a place where they understand the law, but they do not understand the application of the law in relation to maternity and NHS care. So I do think my call today would be for anyone who's working with the maternity services, step up, show the leadership from within your unit, link up with your overseas team, start those conversations, understand where their pressures are, but also understand where their areas, their gaps in their knowledge lie as well, because we may assume that they understand exemptions, but they may not. They may not know where to look for that when it is recorded maternity notes. So, please understand the guidance, help them understand the guidance, and be mindful of their need to work better, but needing some guidance to do that. The other huge benefit of this access guide, I would say, and we've certainly used the previous iteration of this guide to really highlight just the population of women that we're working with here, the extreme vulnerability, the extreme end of adverse outcomes that they experience. And we've heard Megan speak so eloquently of not just of the physical impact, but also the psychosocial impact, not just in the woman, but on their children as well. So I think what's worked well in Oxford is having those early conversations. And I will say the early conversations started with the review of one particular case where a woman and her baby suffered harm through not accessing care in a timely, appropriate manner because of NHS charging a previous pregnancy. And from those early conversations, we were then able to look to the trust guidance on overseas charging policy and be part of that conversation in the revision of their overseas charging policies. We also had to work very closely with our chief finance officer as well, not only in terms of advocating for the women we work with, but also demonstrating that any of the advocacy work and things that we were advocating for fell well within the legal requirements for trusts as well. So I'm conscious there are other very eloquent speakers coming after me. I'm very happy to take questions, particularly anything specific to the Oxford experience. But I would, as I say, I very much welcome this access guide. It's incredibly readable. And I hope that it leads to some very exciting, purposeful joined up working between maternity and overseas teams and financial teams in every single trust across the UK. Thank you.
Thank you very much, Brenda, for some really kind of concise points on how to make things work better. So just to remind you that you please do use the Q&A function to ask questions as we go along, because we do have that session at the end where we can try and address some of your questions. But now it's over to Lauren from Maternity Action, who's going to share our new Voices from the Frontline video.
Thank you. I'm just going to get it up for you now.
I'm Catherine. I am a midwife by background and I'm currently working as a midwifery lecturer at the University of East Anglia and doing my PhD at City University of London, focused on the experiences of refugee women accessing maternity services. Maternal mortality is driven by a whole range of different factors, including 3 which are particularly intersecting that affect migrant women. So these are being of particular ethnic and racial background, being recently arrived in the UK, and living in a state of poverty. And we know that when a woman has just one of these factors, she's more likely to be at higher risk of mortality or morbidity. But when she has all 3 that are intersecting, that risk is multiplied. Not being able to speak English and not being provided with adequate interpretation services, a distrust of the system, a lack of awareness of how to access care. It could be that there's that mistrust is because of the midwife presenting as an authority figure and being part of a broader system of hostility. It could be that the woman simply can't afford to access care. So oftentimes a woman will have to get multiple buses or trains to be able to see the midwife, and when she's living on very limited funds, that is essentially a deterrent to access care. The woman may be deterred from accessing maternity services if she's worried that she's going to be charged for her maternity care, which presents itself as quite a significant barrier. We know that antenatal care is so important for women in protecting both their health and that of the baby. So anything that deters a woman from accessing care will make her more likely to suffer a morbidity or mortality. So women who experience multiple disadvantages accessing maternity care have multiple sort of services that are involved with them throughout their journey. So it might be sort of housing agencies, the Home Office, midwives, safeguarding midwives, social workers. It could be people working within the accommodation where she's living, so people working in hotels, a whole variety of agencies, charities, migrant support charities, citizens advice charities, volunteer doula groups, National Childbirth Trust support. There are a whole variety of people who are within that woman's experience of maternity, but those different parties often don't speak to each other. So there can be all sorts of different things going on, and a woman might assume that everybody's communicating, that there is this great big umbrella of care, but actually what's happening is there's all of this intervention going on, but in silos, which can present sort of quite a disrupted picture of care for a woman. This is compounded even more if a woman faces detention or dispersal during her pregnancy. So we know that maternity care in detention centres is incredibly limited. We know that women who are dispersed during their pregnancy are likely to face significant disruption in terms of their antenatal care. So that might be to do with blood results, it might be to do with antenatal screening, scans, all of these things that are time sensitive throughout a pregnancy. If a woman is going from one healthcare provider to another, there isn't any sort of system of carrying all of that information from one place to the next. Charging for maternity care can be very stressful for women. So it can make women not want to access care, and that can even be an issue in future pregnancies. So a woman who's charged with a previous pregnancy may then be completely eligible for free maternity care in a subsequent pregnancy, but be afraid of accessing care because she's worried about the implications of any potential charges. And again, that doesn't necessarily just affect the individual woman. When, as a community, women know that there is this policy of charging, that fear can be passed from one person to the next, and it can become this shared anxiety about accessing maternity services for fear that you will be charged. The information will be shared with the Home Office that will then affect your claim and affect your ability to stay in the UK. The health implications for women of being charged during their maternity care are an increased level of stress, a lack of trust for their healthcare provider, which may mean they're not likely to attend for antenatal care, which then has a whole host of other implications. So antenatal care has been shown by various reports to be incredibly important across the world for women and their health outcomes, both for them and the baby. And if the woman feels that she doesn't want to access care because of these charges, that will have significant implications potentially for her health. This relates directly to charging because if a woman has higher levels of stress during her pregnancy, she has high levels of adrenaline and cortisol, which are pumping through her bloodstream and then pumping through the baby's bloodstream as well, that will affect fetal development. It means the baby's more likely to be small, it's more likely to be delivered premature, which then has huge implications for the baby's health. But more broadly, thinking about the woman's mental health, I mean, we know that suicide is one of the leading causes of maternal death in the UK. And again, it's something that is preventable with the correct input and the correct specialist support. For midwives who do come across charging, I think it will present them with quite a moral dilemma, because that midwife really wants to build up a rapport with the woman, she wants to develop a trusting relationship, and where there's this barrier to them creating a trusting relationship in that the woman is fearful of being charged, the midwife doesn't want to bring up the charges because she wants the woman to continue coming to her appointments, it then puts the midwife in a difficult situation where she feels she has this obligation to the charges and the overseas visiting team, but she also has a strong duty of care for the woman. So when a midwife has this dilemma of needing to provide care for a vulnerable woman, but also has this issue of them being at risk of charging, it presents them with a really difficult situation morally. So I can think of an example recently where a woman, they really were trying really hard to get this woman to engage with her care. And when the woman presented to the antenatal clinic, as she presented, there was somebody there from the overseas visiting team. And the midwife essentially had to act as a barrier for this person to not go in there and speak to the woman. The woman was a victim of human trafficking, so wouldn't have been eligible for charging anyway. But it had taken them so long to foster that trusting relationship with the woman, to get her to present to the hospital for care, that to then have somebody come in there and be this this huge deterrent and this huge sort of blockage to the trusting relationship was really detrimental. And that midwife then had to be in this position where she's saying, you know, you can't come in, which puts her in a difficult situation professionally when she's working with somebody from the overseas visiting team, as well as that real moral dilemma of needing to provide safe, compassionate, holistic care for a woman to safeguard her and her baby, but also essentially act as border control in asking a woman to pay X amount of money for a service that should be free. Midwives, as part of the broader NHS system, are one of these sort of every contact counts professionals. So a midwife will see a woman multiple times during the pregnancy. She'll see her when she has her baby. The midwife will see a woman for sometimes a few days after she's had the baby in the hospital, and then will continue to visit the woman at home or see them in a postnatal clinic. So across the whole journey of a pregnancy and early parenthood, a midwife has multiple opportunities to ask women questions that will sort of lead on to disclosures of issues surrounding trafficking, modern day slavery, and destitution. And some of those aren't things that can be picked up from direct questions if a woman herself isn't aware that she is a victim. So a lot of it is to do with training and training on what those red flag signs are. Midwives have a unique role in caring for a woman, and there are things that she can do to mitigate those risks to women when they've been charged for their maternity care. And one of the main things a midwife can do is to advocate for the woman, and whether that means writing a letter of support that will indicate that the woman is destitute, that the woman isn't able to pay, that the woman is living in insecure accommodation, whatever it is, a midwife who's able to have the time and the space to really advocate for a woman, that's probably the best thing that she can do to mitigate against some of those worrying health impacts of charging.
There we go.
Thanks, Lauren. So it's open to people to put questions in the Q&A, and our panel will do their best to field any questions that you've got. So please do, anything that you'd like to ask now is your opportunity. So please type it in the Q&A.
I've just got one, Brenda, for you from Raya. She says, can you specify what you ask from the trust when a woman doesn't have grounds for an exemption but can't afford any charges? And how does the trust respond to your requests in these types of cases?
Thanks very much, Ryan. And that's an excellent question, because in many respects, the women who are manifestly destitute and unable to pay probably constitute the majority of the women that I would be advocating for with the overseas team. So the first thing I would do is make sure that you assure the woman, if you believe that she is destitute, assure the woman that she should continue coming to her antenatal care or maternity care. I'm going to come back to that crucial thing that, and it's not, Catherine Letley very eloquently talked about the midwife's role in this. I would say, obstetricians, if you're listening, step up to this as well. Do not leave this just to the midwives to work out. And midwives, talk to your obstetricians, get them on board. But what we had was an established relationship with their overseas team. So, we decided not to other them and keep them at arm's length as sort of the baddies. They're not the baddies. They have a legal obligation to do what they do. And they will blanket invoice anyone who is flagged on their summary on the spine as having uncertain immigration status or are actually not documented. So have an early conversation with them. So I'll give you an example of someone recently who we worked with the trust very closely on. So this unfortunately was where a woman had been sent notification that she would be chargeable, or that she was liable for charging, and that the charges wouldn't apply until after she had given birth. And this was a migrant woman. She had a British-born partner, and the level of stress for that family was unbelievable. But what we were able to do was work with the family to demonstrate not only was she destitute because she was entirely reliant on her British husband, but he was also facing bankruptcy. And so we worked with the trust to provide evidence of that level of destitution. And although the trust can't necessarily cancel that they can't necessarily wipe out the invoice completely in any record of debt to the NHS, they can cancel the charges. So I think it's and I'll be honest and say that I find the overseas team very helpful, and I'm not sure that is going to be the experience across the deck, but they're helpful when they actually know what it is they've been asked and understand that they're working within the legal framework, which again is why this access guide is so important.